You're 46. You're a high performer. You train, you sleep reasonably well, you eat right. But something is off. Energy isn't what it was. Recovery takes longer. Body composition shifting despite nothing changing in your routine. You go to your doctor. He checks total testosterone. It comes back at 385 nanograms per deciliter. He says, "That's normal? You're fine." He didn't check your free testosterone. He didn't check your SHBG, the protein that's been binding up more and more of your testosterone as you age, making it biologically unavailable. He didn't check your estradiol, your DHEA-S, or your thyroid. 385 total testosterone can be fine, or it can represent significant functional hypogonadism, depending on what the rest of the system looks like. This is the problem with a single-number hormone assessment, and it's what we're going to fix today. I'm Dr. Trevor Turner, sports and spine physician and founder of Pravida Health in Atlanta. I include comprehensive hormone assessment in my longevity evaluations for men because in my practice, single-marker testosterone testing regularly fails to capture the clinical picture. Today I'm going to walk through what the complete male hormone evaluation looks like, what the evidence says about testosterone replacement therapy and its safety, and what you can do if your hormone system is suboptimal, whether that involves TRT or not. Here are the hard numbers on testosterone decline in men. Total testosterone in men aged 40 to 70 declines at approximately 0.4% per year. That sounds modest. Free testosterone, the portion actually available to your tissues, declines at 1.3% per year. Why the difference? Because SHBG, sex hormone binding globulin, increases with age. SHBG binds testosterone tightly. As SHBG rises, more of your total testosterone is rendered biologically inactive. A total testosterone of 450 nanograms per deciliter with elevated SHBG of 55 can produce a free testosterone of 6 picograms per ml, below the optimal range. This is why measuring total testosterone alone is clinically insufficient. You need the free fraction and the SHBG to know what's actually available to your brain, muscles, and every other target tissue. Approximately 38.7% of men aged 45 and older presenting to primary care offices have total testosterone below 300 nanograms per deciliter. But because most assessments stop at total testosterone and use a reference range designed to identify only the lowest 2.5% of the population, a significant number of symptomatic men are told their hormones are normal. Let me address the cardiovascular safety question directly, because this is where the conversation has lived for the past decade. The TRAVERS trial, 5,204 men with documented hypogonadism and existing or high cardiovascular risk. Randomized, double-blind, placebo-controlled, 33 months average follow-up. Primary endpoint, cardiovascular death, non-fatal MI, or non-fatal stroke, occurred in 7.0% of testosterone patients and 7.3% of placebo patients. Hazard ratio, 0.96, non-inferior to placebo. The cardiovascular safety concern that had been attached to TRT since the 2010s, not confirmed by the largest randomized trial ever conducted on this question. But, and this matters, testosterone was associated with small but real increases in atrial fibrillation, acute kidney injury, and pulmonary embolism. So cardiovascular safe in appropriately selected patients with careful monitoring is the accurate statement, not no risks. For men who are genuinely hypogonadal, 2 early morning total testosterone values below 300 nanograms per deciliter with compatible symptoms, the documented benefits of TRT include improved sexual function, 2 to 4 kilogram lean mass gains, 2 to 3 kilogram fat mass reduction, approximately 5% annual bone mineral density gain, and a 40% reduction in type 2 diabetes progression when combined with structured lifestyle intervention. In my practice, hormone optimization for men is never just testosterone. I had a 51-year-old CEO come in last year. Symptoms included fatigue, reduced motivation, body composition changes, reduced libido, despite trying to do everything right. His total testosterone from his internist, 412 nanogram per deciliter. Normal. We ran the complete panel. Total testosterone, 412, free testosterone, 7.1, low SHBG, 61, significantly elevated estradiol, 48, elevated for a man, DHEA-S, 102, below optimal for age, TSH, 3.8, subclinical hypothyroidism. His normal total testosterone was being neutralized by elevated SHBG, and converted to estradiol, all by visceral fat aromatase. His thyroid was slightly underactive. He had an adrenal insufficiency pattern on DHEA. We addressed insulin resistance, which drives SHBG elevation and aromatase activity, with metabolic optimization. We optimized thyroid. We supplemented DHEA. 3 months later, free testosterone was 11.4, estradiol all normalized, energy and body composition substantially improved. He never needed TRT. The system needed addressing, not just the headline number. That said, when TRT is appropriate, when the complete picture confirms true hypogonadism with compatible symptoms and optimization of the underlying system hasn't resolved it, we manage TRT carefully, levels every 3 months, hematocrit monitoring, PSA assessment, estradiol management, and blood pressure tracking. If your hormone assessment in your 40s or 50s has been a single total testosterone draw, you have an incomplete picture. Get the full panel. Find a physician who understands the full hormonal system. At Pravida Health, comprehensive hormone assessment is part of our longevity evaluation. If you want to schedule and understand what your hormonal system looks like in full, link is in the description below. Subscribe for weekly evidence-based content. I'm Dr. Trevor Turner.